success doing that, and we look to have some of you today join that effort with us. So moving forward and turning this over to really dig into the medical aspects of these cases, I want to introduce Dr. Candace Dawes, who is one of our partners at Children's National Health System. We always still want to say Children's National Medical Center, CMNC. And so when we talk about doing housing conditions work, I will have you guys like pause a little bit on this medical legal partnership idea, because you're going to hear Children's Law Center staff talk about that later. But I'll tell you now that we have attorneys who are partnering with doctors across the city. We're working hand in hand. We have amazing medical staff who are working with families. They've built a relationship with those families, and they're doing everything they can from the medical aspect of treating families. And there are root causes to some of the medical issues that they're treating where lawyers can step in and make a difference. Housing conditions is an example of that. And so one of our partners that I'm very excited to introduce is Dr. Candace Dawes. She's a board certified pediatrician practicing in Anacostia, DC. She practices with one of our CLC staff members that you'll hear from later, Kathy Zeisel. She's currently the associate medical director. She's a clinician with Impact DC, and so you're going to see and learn more about Impact DC through her presentation today. I won't steal her thunder. I can't do it as well as her anyhow. So I'm going to pass it along to her so that you can hear more about the medical aspects of this work. And once we transition from the medical aspect, we're going to jump into what lawyers do and how we can assist our medical partners in these really important cases. Thank you so much. And then feel free to click through with that. Okay, perfect.
Good morning. I'd like to say, first of all, thank you. Can't express how much it means to the families to have an advocate behind them, not just a pediatrician, but also a lawyer. It makes a huge difference when you can say, you'll have to speak with my lawyer. So I'm just going to actually talk about the medical aspects of housing conditions and cases. I'm going to really try to keep things very brief in terms of asthma and the pathophysiology behind it. You all are lawyers. You are not physicians. That part isn't important. So I'll break it down just as simple as I can. And if at any point you have questions, you need me to clarify things, just ask me to repeat it. So I don't have any disclosures. The only disclosure is that I would one day like to cure poverty, but I am employed at Children's National Health System, and I have no other disclosures. So briefly, the outline, we're going to talk about what is asthma, and again, very briefly about what asthma is. We'll talk about disparities in pediatric asthma and talk about specifically the disparities here in Washington, D.C. We'll talk about some indoor air quality in the urban environments, and then finally, I'll wrap up with what is Impact DC and how we help children in the community. So really briefly, this is just the pathology of asthma. So when we talk about asthma, we talk about upper airway and lower airway. So asthma is really just going to be our lower airways. And in brief terms, in asthma, of course, our lungs are affected, right? The airways get inflamed, they narrow, they produce extra mucus, and they make it very difficult to breathe. So if you can see a normal airway versus an asthmatic airway, at baseline, that asthmatic airway is going to have a lot of mucus in there and a lot of inflammation. So already the airway is narrowed. When you talk about a kid or an adult who's having an asthma attack, you'll notice there's even more inflammation, there's even more mucus, you're gonna get tightened, smooth muscle around your airway, which is gonna make it really hard for air to pass through. And then you get air trapping. So if you can imagine essentially trying to suffocate, that is essentially what children and adults who have asthma experience when they're having an asthma attack. It's a combination of your genetics, you can't help who you are born to, but it's also a combination of the genetics and triggers, so environmental things that actually trigger the asthma. If we talk about what the national experience is with pediatric asthma, there are 7.1 million children who are less than 18 who live with asthma in the US. And this is data from 2009. Sorry, I don't have any more updated data. It is the most common chronic disease of childhood. And if you look at the breakdown, there are about 157,000 hospitalizations, 640,000 ED visits alone for it, and 10.5 million missed days of school for asthma. So it's a big problem. The morbidity is highly concentrated in urban, poor environments, like most of our chronic medical conditions. If we look at the prevalence of asthma, you will see the top line is black, the middle line is white, and the blue line under there is Hispanic. If you notice that African Americans have the highest rates of asthma, and this was data from 2001 to 2010. And if you look from 2001 to 2009, the number for African Americans has almost doubled, right? It went up about 50%. More than half of the children who miss a school day miss it due to an asthma attack. And if we look at the prevalence of asthma amongst DC residents who are aged 1 to 17 years old, if you notice, those rates have actually jumped almost 18% from 2005 to 2010. So the question is, what is actually going on that is making these rates actually go up and not going down? If we look at ED visits for asthma, so this is, excuse me, ED visits per zip code in Washington, D.C., and this was data from 2014. And these were any children who made a visit to the emergency room, and any place in that emergency room visit, there was a diagnosis of asthma. So if you look here, let me see if I can use the pointer. I'll come over here. If you look here, the red areas, actually, no, I'll step back. The microphone is here. If you look here, the red areas are wards 7 and 8. Those are our wards in Southeast and Northeast. If you look, the ED visits were 48 to 75. So if you look, most of the health disparities are concentrated in wards 7 and 8 for DC. That also correlates with the poverty in DC. If you look again, the red areas concentrated in wards 7 and 8. So again, it's showing that the rates of asthma are in the areas where we are most poverty stricken in DC. If you look at the rates of unhealthy housing and poor asthma control by zip code, again, you will notice that this is concentrated in wards 7 and 8 in DC. So if you look at the blue dots, it gives the rate of poor asthma control, and the largest dot is 78 to 81%. Again, you're going to notice that that's concentrated in wards 7 and 8, and a little bit in wards 4 and 5 there in the middle. There's a significant association between unhealthy housing and poor asthma control, and I cannot say that enough. Nearly 25% of children with persistent asthma in this particular study lived in unhealthy housing, and that's where lawyers come in and actually help. If you look at a conceptual model of pediatric asthma, you see there's a child with asthma. There are multiple things that actually come into play. So there are individual and social factors. So there are your genes. There are the physical conditions. There's the socioeconomic status. There's the stress. There are the hormone levels. There's the environmental factors that we can actually do something about, right? There are the allergen sensitization and exposure. So that's your dust, that's your mold, that's your cockroaches, that's your mice. There are viral infections, which we can kind of control with good hand washing. Weather changes we can't. Outdoor air quality we can't necessarily control. The medical factors we can also control. That is good access to care, quality of care, medication plans, adherence, techniques, and immunizations. All of that leads to whether or not you're going to have low morbidity and high morbidity. With low morbidity, you have few symptoms, few school absences, few ED visits. With a high morbidity, you have many symptoms, many school absences, and many ED visits. So we're trying to shift the pendulum this way. There actually are guidelines for asthma. So we as physicians have guidelines that we can actually follow. There's step therapy that we initiate medications, control patients, et cetera, et cetera. These guidelines come out every few years, and the last set of guidelines came out in 2007. In these guidelines, they basically got us towards using inhaled corticosteroids. They got us to having a written asthma plan that the nurses can follow, the families can follow. They ask us to assess the asthma severity, assess and monitor the asthma control, schedule periodic asthma visits, and in addition, control what we can in terms of environmental exposures. So when we talk about these environmental exposures, we're talking about mold, we're talking about roaches, and we're talking about any other pests that can actually access. And this is a common thing that we see over in Ward 7 and 8 in terms of housing conditions. There was one particular case where I'm going through just a routine well-child checkup, and I'm asking the child, are there any pets at home, any animals at home? And the child said yes. And I said, what kind do you have at home? And they asked, did I include the 30 roaches that crawl on the wall? Mom was completely mortified, but the kid was completely honest. And that was a way that we could get Children's Law Center involved to actually help the family. So is there anything that we can do? And by we, I mean all of us actually in this room. So there was a study of, sorry, let me back up. Is there anything we can do? We actually practice best evidence, right? So there's recommendations for reducing dust mites, reducing mold, reducing rodents, reducing roaches. There's also evidence about tobacco smoke and other smoke exposure, such as marijuana and candles. And there's also evidence about the appliances, whether or not a family has a vacuum in the home, if they do have carpet, or if they have an HVAC system, whether or not that's actually cleaned routinely, and who's responsible for cleaning that. If we talk about, again, the evidence for reducing these environmental exposures, there was a home-based environmental intervention study to reduce asthma morbidity. And that was a systematic review of about 22 studies from, I think, 1966 to 2008. And the aim was to actually assess the home and change the environment to decrease the exposure to triggers. And so this was a CDC multi-agency, multidisciplinary task force, and all interventions included some level of environmental remediation or optional other services. And this is best evidence for multifaceted interventions, and it was the most benefit for children. So that study actually showed that they reduced asthma symptom days of school missed, hospitalizations, ED visits, and days of school missed. If we talk about another study, there was an inner city asthma study, and that was, again, a study where children were randomized to an environmental intervention group, and they evaluated allergen sensitivities and whether or not there was a difference in allergen sensitivities. And so 937 urban children with asthma were included. It was a 1-year intervention, and there was a 1-year follow-up study. And the interventions were aimed at patient-specific triggers. So allergen impermeable mattresses, pillowcases, HEPA air filters, vacuum cleaners, professional pest control. Those were all some of the interventions that they actually put in place that were specific to these children. What did the results show? It showed fewer days with symptoms, a greater decline in the allergens at the home, and this actually persisted through the 2nd-year follow-up. Declines in dust and cockroach antigen levels, which correlated with fewer complications of asthma. And it was, they actually did a cost-effective analysis, and there were 38 more symptom-free days. And in the end, this actually saved money. So again, what did this show? This showed that if you reduce the environmental allergens, you could reduce the symptoms of asthma and the overall quality and care of the child. So now a little bit into what are some of these environmental things that we often ask lawyers to get involved with, right? So maybe not so much dust mites, but there was a Cochrane review in 2008, which really didn't show any consistent significant effects for any method. But still overall, as physicians, we do recommend reducing the amount of dust mites. We definitely recommend allergen barrier encasement. So as part of Impact DC, we actually give out pillowcases. Wash bedding and our stuffed animals weekly. We try to stay away from the stuffed animals, but in those cases where you cannot, we ask that you do wash them. We ask that you keep humidity low, that you use HEPA filter vacuums, that you actually replace your pillows, and that the carpet is removed if at all possible, but just make sure that at least you vacuum on a regular basis and that the carpet is cleaned regularly. And if you actually see, a third of the weight of your pillow after 2 years is consistent of dust mites, dust mite excretion, dead skin, bacteria, and saliva. Mold and mildew. Here's something where you can actually get involved. So mold and mildew, what do we want to do? We want to prevent moisture control. We want to control the moisture. So you want to keep the humidity less than 50%. You want to make sure that we vent bathrooms and clothes dryers. We repair any leaking faucets and pipes. You want to discard any molded items and any carpets that are molded, and you want to make sure that the family can clean the small areas. So scrub versus bleach, we usually do not recommend any kind of household items that would trigger the asthma, but if it's a case of you need to get rid of the mold versus you need to clean with bleach, you have to clean with the bleach. In the large areas, we want to make sure that those are professionally cleaned. So that should be the owner or the landlord's responsibility and not actually the family. Roaches. So a lot of people may know them as water bugs. If there's one visible roach, there are 10 behind the wall. So where there's one, there are more. They like dark, they like clutter, they like tiny spaces, they like food, and they like water. So this is where we ask families not to eat in the bedroom, to only eat in the kitchen. And by eating in the bedroom, we mean even their pets. So if you have a dog, making sure that the dog also eats in the kitchen, the dog eats nowhere else as well. Because those little droppings can be a source for rodents. It is very difficult to get rid of them, especially if it is a housing unit, and so that's where lawyers again can get involved. There's not much that the family can do on their own if there's an infestation problem in the whole housing unit. A lot of my families have actually decided to do things on their own, and to get rid of roaches and mice, they actually have cats in the home. That doesn't actually solve the problem, because that actually makes it worse, because the cat might be allergic to the child may actually be allergic to the cat. So roach interventions, what can we ask families to do? Contain, remove the food and the garbage. Seems like a simple thing. Use poison baits, traps, boric acid. Please no sprays. Again, that worsens the asthma. So we want to try to control them if we can without sprays. We want to keep the home clean and free of clutter. We want to fix any leaking faucets, and we want to clean spills, and we want to be able to caulk any cracks, because those can be areas where the roaches actually get into the home. Rodents. So you want to make sure that we fill any holes. They can come in through something as small as the size of a dime. So make sure that all holes are filled. You want to vacuum and you want to clean well. Again, you don't want to leave any food for the rodents. You want to store food in thick containers. Low toxicity pesticides and traps will work. Again, we don't want anything that's going to be really toxic to the child to inhale, because that will again worsen their asthma. And we ask no food in the bedrooms, which can be really difficult. We also ask kids not to sleep on the floor. We find that a lot of children actually sleep on the floor. If they sleep on the floor, especially if there's carpet, it worsens it. And if you sleep on the floor, then you tend to eat on the floor. So that's something that we also ask them not to do if we have a choice. And mice are actually allergens in 30% of homes. And 75 to 80% of homes in DC actually have mice. So even if you can't see them, they may still be present there. And I don't know what's so fun about that, but it's just a fact. And a mouse can leave up to 3,000 drops of urine on surfaces each day. So in addition to the mouse droppings that they leave urine. And again, these can be allergens for children and adults with asthma. Integrated pest management. So pest control strategy that involves, again, the least toxic methods first. We don't want Raid. We don't want any of those sprays. Strategies vary, but they can often include mouse traps, sealing the cracks or the small holes that are in the home, resident education, so not just to get education about the family that lives in that particular apartment that you're dealing with, but maybe as a resident at large, educating everyone who lives in the housing complex to not eat in the bedroom, make sure they seal their cracks, make sure their trash is taken out in a timely manner. You want to make sure that you contain all food in storage containers, and you want to make sure that there's always generalized cleaning that's done to reduce any of these allergens. And then you want to have strategic placement of the pest control treatments, and often in the form of bait traps or gels, which can help. Secondhand smoke and odor. So a lot of families think that because they go outside and they change their shirt, that a lot of that smoke is not still in their clothes, but it is. It's in the home environment. So we always encourage parents and support them to quit smoking if and when we can. We want to make sure that the home and the car are smoke-free. So smoking outside, changing clothes, washing the clothes, washing their hands are all great reductions in harm, but the best thing is smoking cessation. We want to choose smoke-free social settings. That's usually not a problem in DC. And we want freestanding HEPA filters, and we usually want one per room. We also have started to educate more about marijuana and other sources. So as marijuana is legalized in multiple states, we want to start talking about that as well, because that smoke can actually trigger asthma as well. What about other indoor air issues like pollutants? So all forms of smoke, whether that's incense, candles, fireplaces, kerosene heaters, we advocate against them. We want to make sure that families have exhaust fans in their home. We want to ventilate the room if there are fuel burning appliances that are used in the home. And we want to avoid use of products which emit irritants. So perfume, cleaning supplies, air fresheners, we don't want any of those actually in the home. And we want to make sure that either the family or the landlord maintains the HVAC system. So that's changing the filters, going in and dusting, making sure that there's no mold in there. And so how do we help? So I am a part of Impact DC, and I am also a general pediatrician in Southeast DC. So I work with children in wards 7 and 8. So Impact DC, this is our specialty asthma clinic. We actually have clinics 4 days a week at the main hospital and 2 of our sites in Southeast DC. So we are strategically placed where most of our asthma is and where most of our core housing conditions are. So there's easy access to a medical provider there. So we pull children from the community. We pull children from the emergency room. We pull patients from the inpatient side of the hospital. And we also have referrals from Children's Law Center, school nurses, from all over. So ideally, if a child is seen in the emergency room or they are hospitalized, we like to touch base with them within 2 to 4 weeks of either their emergency room visit or their hospitalization. Again, based on those NIH guidelines for asthma care, we definitely follow them. So there are 3 areas of focus that we actually do with the families. That's education. So there is intense education on asthma and the control of its triggers. These appointments are not short appointments. They are about 2 hours long. The clinical care, that's the medication and a written asthma action plan, which tells the patient, the family, the school, any caregiver what to do about their asthma and when to act on their asthma. And then there's care coordination. So we can link them to primary care if they do not have a primary care provider. We can touch base with the school nurses depending on what school they go to in DC or Maryland. And we actually have community resources for them as well. So we have some partnerships with an organization that can actually go out to the home, do an assessment of any triggers in the home and help to alleviate those. We have a partnership with Children's Law Center. So if there are any housing conditions that we can get them involved in, we actively engage them. And we also do community and professional outreach, advocacy, and research. If we talk about education, these are some of the materials that we use. So again, we go through what asthma is, how it affects individuals, how it affects the lungs, and different allergens and exposures that can affect their asthma. We go through how to take asthma medication, what supplies you need to take the asthma medication, and we also give written materials to match that. We give personalized asthma tools. So on the left-hand side, you'll see an asthma action plan. So this is a documentation, a medical documentation that tells the school that the child has asthma. It tells the parent that the child has asthma and what to do in each zone of their asthma. So green is well controlled. Yellow is not so well controlled, maybe something's triggering it, and red is to the point where they're having an asthma attack. They need to go to the emergency room or see their primary care doctor. And so in order for each child in DC to actually have their medication at school, and in order for the school nurse to be able to administer it, they actually need one of these forms. And then on the other side, it actually tells the family how to use an inhaler and a spacer. And a good majority of the families don't actually know how to use it, or actually don't even have one. So this is good information for the families to have, and this is what they get in their visit. We also direct people to our Impact DC website, so it can be found on the Children's National website. There are great handouts there. There are great videos there. They are in Spanish and in English, and there's good information for providers as well. So if there's a provider who needs information about resources, referrals, etc., it's on there. You can actually also meet the team on that page as well. And this is just highlighting the videos, some of the videos, informational videos about how to use inhalers and spacers. So in summary, there are disparities in asthma prevalence and outcomes in Washington, D.C. They're striking, they're persistent, they're not going anywhere. Several common local environmental exposures are linked to poor asthma control outcomes. So mold, mildew, pest, rodents, smoke. These are all things that we can actually control for. We cannot control for your genetics, but we can control for these. There's good evidence that exists that addressing these exposures can improve asthma quality and control and the life for the children. There are multifaceted approaches that are needed and multidisciplinary teams, the pediatrician, the family, possibly lawyers. And you all can make a difference. I have seen it happen in everyday clinical setting. I have seen lawyers come in, change the home environment and change the school environment. And if you need resources, there are lots of resources here in the back of your packet on the last slide. And finally, with Impact DC. Any questions for me?
I'm gonna jump in with Candace with questions. I'm Kathy from Children's Law Center, and Jen's gonna introduce me, but you guys can ask Candace questions, but I wanted to thank Candace because she is an awesome pediatrician that we work with. But Candace, can you tell us for a second about if we come across, so we in our cases, the reason we have Candace talk is that almost every case you have, one of the kids has asthma, which is how the cases get to us, right? Like the kid comes to Candace. Can you talk to us about, like, you mentioned a kid comes in and how do you figure out that the kid has housing conditions, like in the interview, that you guys come in and they end up with you in an impact room because the kid has just been hospitalized or came to the ER, right? So how do they get to you guys in impact? Can you talk a little bit about sort of what the family's going through that they got to you guys?
So Impact DC, you can get referrals from multiple places. So we get referrals from pediatricians with cases where a child is on controlling medications. They can't quite figure out why the child's asthma is not well controlled, or there's a family who has poor education about asthma, doesn't understand the importance of asthma, and needs further information. The emergency room, so they track and see how many visits a child has had for asthma. And if it's like, oh, they've had 6 visits in the emergency room with steroids, that's somebody that needs to go to Impact DC. If you've been hospitalized, every patient who's been hospitalized essentially gets referred to Impact DC, but especially those who are high risk. They've had multiple hospitalizations. They've ended up in the intensive care unit. They make it to Impact DC. And during that visit with Impact DC, we try to figure out where there's a disconnect. There's got to be a disconnect somewhere if the child is medically managed and well managed. So first of all, we're trying to figure out, are they medically managed and well managed? And if that is the case, then we try to figure out what else is leading to this child coming to the emergency room multiple times, the pediatrician not being able to manage their asthma, or they're going to the emergency room. And so one of the things that we really hone in on is the housing. If you can understand, families are not always as forthcoming the first visit when you see them about housing conditions. The child that I told you about who had roaches in the home, and he disclosed that those were his pets. Mom was mortified that he actually told me that. She was completely embarrassed. But when we let families know that we can actually help with that, not just saying like, oh, okay, you have pests in the home, you have mice in the home, and next, why are you not taking your controller? We can actually help. So I think actually probing about housing conditions is really important. We actually get in the nitty gritty. Where do you live? Do you live in a house? Do you live in an apartment? Do you own that house or the apartment? Do you have carpet in that home? Do you use incense? Do you use candles? Are there any rodents? Do you eat in your bedroom? We actually ask all of those questions.
And do you find that when a lawyer gets involved and help with the conditions, that the families come back to you as a pediatrician in the primary care setting and report that that does make a difference?
Yes, it actually does. It makes a huge difference. So we as pediatricians can also write a letter that states, the carpet needs to be removed in the home or the mold and the mildew needs to be addressed. But I've found that is least effective, or not as effective as saying, Children's Law Center will get involved, and we'll have an advocate that will advocate for you and fair housing conditions. So I often have families come back to me and say, it was great. The landlord finally removed that carpet. I've worked with several of the lawyers here, and the families know them by name, know their numbers, can easily access them. And I think it makes a huge difference. We've seen great outcomes that have come out of getting the lawyers involved.
Does anybody have questions for Candace about sort of the medical part of it? I know the medical part seems weird to come to a law training and hear about it, but you guys may get, this is something that, I know some people here, we always get questions like, my kid has asthma, but also in the cases, you'll have kids that have asthma. So does anybody have questions about that, or about sort of the pest management part of it that comes up in our cases, or any of that? You think of any? The great thing about it is the doctors are easy to reach in our cases.
Yeah.
Thank you very much.
There has to be one question.
Come on, guys. Don't be shy. Think of them. I guess your presentation was so clear that everyone's saving their questions for later. Oh, there's one in the back. Awesome. So, okay, so I'm going to handle that one. So the question was, there was a question about that cleanliness was really important to keeping pests out, and is that always a priority for everybody in the client households that we meet? And I think, as with anybody, like, I have kids, and sometimes my house is a mess because my kids are messy, and it's hard to keep little kids from making a mess. Just this morning, I was like, don't eat oatmeal and get it all over the floor. It can be hard. And so sometimes, our clients might not have the resources to buy the containers, or they might not have the resources to keep things in, an expensive HEPA vacuum that they need. And so sometimes we'll match them with programs in the city that can help them buy the things that they need. Or those of you from law firms, sometimes law firms are able to assist in buying the expensive containers, or Impact sometimes is able to assist with the the special things that go around the pillowcases. By the way, I always feel like we should sell pillows. I always buy new pillows at the end of this training, every time we do this training, because I'm like, 1/3 of my pillow is dust mites. I need new pillows. But most of our clients, it's really about information. So when the Impact educators talk to them about, oh, you need to keep your cereal in a plastic container, if they just didn't know that, that's just a piece of education. I didn't know that till I started doing these trainings, that would be a better way to store things. So I started doing it that way also. So sometimes it's education. I don't think it's that people don't value that as an important thing. It's just time and sometimes money.
So the question was, what's driving that increase in asthma from 2001 to 2009? And we're not really sure. Of course, I have my own theories. With gentrification of DC, you are moving populations essentially to 2 wards in the city, right? Those are the wards where, for now, there's affordable housing. And so those areas are getting overpopulated, and that's where you're pushing a large majority of the population who has poverty and asthma. And I think overcrowding also has something to do with it.
And another way of seeing the statistics that you saw here is that kids in Ward 7 and 8 are 20 times more likely to end up in the hospitalized or in the ER than kids in Ward 3, which is the wealthiest part of DC. And Children's National sees 1% of the emergency room visits for asthma of the whole country. So of kids that go to the emergency room for asthma in the entire country, Children's National sees 1% of those kids. So they see an enormous amount of kids with asthma, and a lot of those kids go through impact. So we have a lot of really good data on kids with asthma, and so their research arm is getting a lot of really good information.
And a third of the population of children who actually live in the city live in either Ward 7 or 8. So there's a large population of children in the city that actually live there.
So kind of the worst cases of asthma that you see where there's a lot of, was it red zone days that you were referring to? How many days of school would a child typically miss?
So the question was how many days of school a child misses with an asthma attack. So with every asthma attack, it's about 4 to 5 days that they actually miss of school. So if you think about a child who has had 5 asthma attacks in a school year, that could be 20 some days of school.
And don't forget, their parents miss work. Their siblings often miss school because they all are at the ER together, right? So it's not just this one child missing school, which is really bad, but it impacts the whole family and impacts the parent being able to keep a job. It can really impact like your intervention, keeping the kid out of the hospital, can impact the whole family's like social well-being.
And a parent who misses work is at jeopardy if they don't have FMLA of losing their job.
Right.
It just further pushes the
Their
poverty
housing
cycle.
can be at risk.
Mm-hmm.
Other question?
Mm-hmm. Mm-hmm. So the question was whether why they haven't updated the guidelines in so long. It'll be out soon, but there's a lot of data that actually goes into it. So it'll be out soon. I think 2019 or 2020, there will be a new one that's out.
And as you'll hear when we move to our part of it, we're part of a medical legal partnership. So if you have questions in your cases, we really can connect you back with doctors if you have more questions that come up about asthma as you move through your cases that you take from us.
Yes. And hopefully you will take a case.
Yes.
Or 2.
Thank you so much, Candace.
Thank you so much for coming, Dr. Dawes, Candace. I mean, Kathy, you know, you're on a first name basis. You guys could be too. So one thing I wanted to mention before turning it over to Kathy and Evan to talk about the legal aspects in these cases is just to note that the cases that are coming for pro bono placement and the cases that we're handling in-house at Children's Law Center, we will often see, because we're collecting this information in our intake, we'll often see that there's been a doctor, just like Dr. Dawes, involved and often writing letters to the landlord and saying, remove the carpet, repair this issue, actually get rid of the mold. We see a lot of mold irritants in these cases, and either nothing is done or it's painted over. That is something that we see a lot of, and that's not getting rid of it. And so, of course, the health issues that the child and the family is facing isn't getting improved when the repairs are really not adequately made, if they're even attempted. So we see a ton of this. We see, you see the couple of cases we have available now, and there's one there where we're questioning whether there's an impact on this kid's asthma. And so it's very common, and you're hearing from this doctor telling you all of these different statistics and how important all of this is medically. And it strikes me every time we get an intake where a doctor, just like Dr. Dawes, has written a letter and it's gone to the landlord and it said, there's a kid, this kid is sick, and these things in the home need to be repaired, need to be addressed, and it not actually happening. And so that's where having Esquire behind your name really does make a difference, and lawyers being able to pick up from that point and follow up on the violations, because we're talking about, things that maybe the family can do in the home to keep the space clean, different education aspects, all of that is important, but there are housing code violations that are going on, and that is not the family's responsibility. So that's my little spiel that I wanted to follow up on. So we're going to turn it over to the legal aspects. And as I mentioned a couple of times, these folks could be your mentor. So Kathy Zeisel is a senior